So this session, we're discussing two of the major complications of TAVI, specifically stroke and acute kidney injury. Stroke, probably the complication that our patients fear the most. In the partner trial, there was certainly an excess of stroke in the TAVI group. How much of a problem do you see stroke as in TAVI?
So the problem was emphasized in the partner study because they used an old device, and many of the centers, participating centers, were at the beginning of the learning curve. One of the major determinants of stroke, in my mind, in my view, is the way to cross the valve, the aortic valve. They use a different technique from European countries, so they make different attempts with the wire, whilst there are some maneuvers with some specific catheters, such as the Amplats 1 or 2, that can allow to cross the valve in less than 1 minute without any additional maneuver in at least 90% of the patients. This is the first point. So in the following studies and registers, the rate of stroke is no more than 3%. So in Europe, the average rate of stroke is, overall strokes is 3%, in Italy too, and divided in two by major and minor strokes, with a slight increase by 1 or 2% in up to 1 year. So I don't think that all the new devices that have been invented for protecting from stroke will be useful or adopted. I personally won't use. Okay, I personally won't use that.
Okay, Enrico, what do you think about stroke and TAVI?
Yeah, of course, stroke is a major issue, especially for very elderly patients. I think we can do something. I'm a little bit not in agree with you because I think the new devices, new deflectors can play a role. Of course, if we do not do aortic valvuloplasty before the procedure, this can maybe reduce the risk of embolization. Of course, we can have more different devices that can help in deflecting this material coming out from the valve. So we can set up some strategies in order to reduce this risk, which is quite low compared to the first series. So right now it's between 2.5 and 3%, with lower rate in transapical, probably because we do not cross the arch. So again, it's unpredictable, but we can do something for that.
Yeah, I think we have to be careful about dismissing what can be a devastating complication, but I do get the feeling that TAVI community is getting a bit less bothered about it. Lars, what do you think?
I wouldn't say...
Not less bothered, but we're not seeing it as
But I
much
think
as we
stroke
thought.
is also a complex complication to talk about. First of all, it's probably in the range of about 3% nowadays, the stroke. But you can divide it up to the stroke you have during the procedure, which is maybe 1 to 1.5%, and then the stroke coming the following weeks after. And I'm sure that's two different mechanisms we're talking about here. And what we're addressing with the deflector device or the filters is stroke happening during the procedure. So we're talking about 1.5% of the cases. So if you need to introduce a filter, I mean, that's what you're addressing here. If you want to do the stroke in the first couple of weeks, we're talking about medical treatment probably. The other issue is there's quite a few studies out now with MRI of the brain showing that about in the range of 70 to 80% of these patients have new silent lesions. And we can argue whether we should treat those silent lesions or we should just accept it if it doesn't have any clinical relevance. If we think those silent lesions will have an impact, particularly if we move down to younger patients, that's a completely different story.
Okay, all right. So there's all these devices on the market. Anyone using them?
Not yet.
Well, I've used embolic protection devices for a few patients. And if I put my tuppence worth in as well, I think stroke has reduced. It's much, much lower, but it's still an issue. And again, I think we don't quite understand procedurally what's the most important driver of stroke. Is it delivery of the system around the aortic arch? Is it balloon valvuloplasty? Is it placement of the valve? So there is a lot that we need to understand so that we can devise mechanisms for treating procedural stroke. It's low, but it's an important and devastating complication. We have used embolic protection devices in a number of patients who otherwise have contraindications to TAVI. So there are a proportion of patients we turn down because they have, for example, mobile structures on the aortic valve, perhaps thrombus in the atria or the ventricle, so who have no other option. So we've used embolic protection devices in 1 or 2 of these patients who we think are at much higher risk of stroke. But again, it's not following any particular protocol. We are doing it in patients we think are high risk. So I think we do need more information on these patients and what the risk is, and it would be useful to have more studies looking at exactly what drives peri-procedural silent or non-silent infarcts in these patients.
To my knowledge, there is no evidence that the protection devices reduce the stroke rate.
No.
So,
And I guess we're all...
I think we need trials for that.
We're all slightly concerned that we've got what is already quite a complex procedure and we're adding to it by ramming things up the carotid
They're not that
arteries.
easy to deliver.
Yeah, absolutely.
So we've used them in 2 or 3 occasions. They are not easy devices to deliver. They're radial devices that sit and sometimes can interfere with the delivery system of the device. So it's not a perfect solution, but I think it is an important complication. And I think that we are.
But if you're targeting 1% of the population, you need a device which should be very efficient and very safe to make any difference for the patient.
Well, talking of targeting, so does the registry data tell us anything about who we should be targeting? Who's at high risk of stroke?
I haven't seen any data on that.
There's nothing.
you should implant 100 of devices in both arteries for avoiding a potential stroke. You don't know if it is worth it.
Yeah. Or will they cause
Which are the
strokes?
consequences of the implantation of the devices also.
We're in a data-free zone, unfortunately.
Yeah, okay.
And you can also say one thing that has been shown have less complication is a procedure who's done quick. If you do a long procedure, you have more complication. And I don't know how long it takes, but let's say you spend 10-15 minutes to fiddle around with your filter. That may add a complication onto the procedure.
That's right.
And balloon aortic valvuloplasty, what do we think about that as a risk for post-procedurally? Well, pre and post, I suppose.
Yeah. From the data I have seen from transcranial Doppler where the hits are, is during the valve deployment itself. It's not as much the balloon valvotomy, which you would expect and crossing
Which
the
would
arch.
absolutely make sense. Yeah. Because if you look at the patients who have balloon valvuloplasties as a standalone procedure, the stroke rate is very low. And one has to postulate that it's the delivery of the device itself within the aortic arch and atheroma that causes disruption. But who knows?
And that would support doing transapical cases then?
Or not ballooning. Or doing no predilatation, which you can do with the transapical very easily. You can do it with a transfemoral procedure as well. We did it.
Increasingly?
You can do it. You don't have to predilate with a transfemoral procedure. You can nose the balloon across. And
how often are you not predilating?
We are still predilating for our transfemoral cases.
Me too.
The same.
But I think that may
There's
change.
selected cases where we don't do it. Valve-in-valve procedure, we don't do it. Pure aortic regurgitation. But I mean, that's very few. One or two
Basically,
percent.
your standard protocol is to
Just to be precise, in valve, we do not do
So
predilatation.
in normal,
Exactly.
in
normal
native
cases,
aortic valve, we predilate. We don't predilate as you
Involved in
do
valve,
in
because
some
those
cases. Select
pieces
cases.
can be released.
Okay. So on to acute kidney injury. So Jonathan, who are the people you're most worried about the risk of acute kidney injury? And what do you do about that?
Well, again, the drivers for acute kidney injury are slightly different from those in the PCI population. There it's related to contrast volume. But the drivers in terms of patients are the patient group that we treat for TAVI. So they're at higher risk. Diabetics, elderly patients, fragile renal function to start with. Certainly studies that we've done looking at acute kidney injury seem to suggest that it's related to not just pacing trains and length of the procedure, but also the inflammation induced by the procedure, and that may be a driver. There may be a slightly more biochemical reason why some of these patients have acute kidney injury, but generally speaking, it's those patients at risk with their baseline demographics. So GFR below normal or at the end of the normal range, low body weight patients, diabetic patients, these are the group that tend to have more kidney injury. But a longer procedure, longer pacing trains, more hypotension during the procedure, all of these drive acute kidney injury. Contrast volume and contrast load certainly in our institution is low for most of these procedures. That's not the driver.
But does contribute.
Contributes, but we use relatively low volumes because we're TOE
to
guided,
prevent
and we can do procedures with very, very small amounts of contrast. We don't do aortograms routinely, so 50, 60 mils of contrast would be reasonable for an Edwards device. It's not that drives most of the acute kidney injury here. It may be different for the core valve population where you use more volume of contrast. But I think length of pacing trains are important. Length of the procedure are all key in determining who is going to get acute kidney injury.
So you're not doing anything specific to reduce acute kidney injury, you're just having efficient procedures?
I think that's the key thing. I think you can fluid load the patient beforehand if they've got a good ventricle. I think the use of bicarbonate and N-acetylcysteine is frankly useless. But generally it's a quick, efficient procedure that will keep your AKI rates down, in my opinion.
Mm-hmm. Lars, is core valve any different?
No, I think it's the same. I have to say we see very, very few patients who have renal failure after the procedure. Not saying that the creatinine is just not going up temporarily and come down again, but it's not any clinical issue. And I think it's the same. It's fluid up front, keep the pressure up, give a low volume of contrast, and that's it.
I think that's right. A lot of the registry data that got us all excited or worried about renal impairment was based on increasing creatinine, which of course is not intrinsically a cause for concern. I agree. I don't see it very often at all.
But I think we have much more skill now. We can do the procedure faster. We can do it with less contrast when we used to. So it's.
I think we have learned a lot during the last 3-4 years.
What we do, we use a system which is correlated and linked to the injection system with a continuous flashing. There is an injection of fluid related to the injection of dye, and simultaneous diuretics injection. So we flush continuously. We wash the kidneys, and many patients, they have a reduced creatinine after and we use also in high creatinine patients undergoing a complex PCIs. And so the cutoff is 30 glomerular filtrate.
Mils per minute.
Yeah, in these cases we put the Renal Guard is the name.
Okay. Yeah. And that is, yes, and so intuitively one would expect that to be helpful. Is there any data out on Renal Guard yet?
Observational data, we use a lot, and almost always, we have a reduced creatinine level after the procedure, even a longer procedure with a big amount of dye in patients with renal insufficiency.
Anyone else using Renal Guard?
Yeah, we do it, but we don't use it on a regular basis. I mean, in some patients with high risk of renal insufficiency, and it works.
Good. Okay. So, to summarise, stroke remains a potentially devastating complication, but is perhaps not quite as prevalent as we previously thought it was. Its etiology is complex and maybe partly related to technique, including wire technique and balloon aortic valvuloplasty, both before and after implantation of the valve. There are devices available, but there's generally not a great deal of enthusiasm for them at present, and there's certainly no data to support their use. Renal impairment, again, complex etiology, and the consensus is that the best way to avoid it is just by having an efficient and brief procedure, avoiding hypotension, and we do, of course, routinely reduce contrast load, and we tend to prehydrate as well, more on a sort of historical basis than based on fact. Okay, thank you.